Well, it's nice to see everyone again. As David just mentioned, I'm going to be talking today about chronic myelomonocytic leukemia, which, although is a disease that falls in the same category as atypical CML, it's certainly a much different entity with respect to the incidence and the data available. So with that, the objectives of the talk today are, one, we'll describe CMML in the context of overlap syndromes. We introduced the concept of overlap syndromes yesterday evening, and especially the fact that these diseases lie at the interface of WHO morphology. And so there's always a general discomfort in pathologically diagnosing these diseases with certainty, which is certainly the case in CMML. And I'll explain and hopefully highlight some assays which may improve that pathologic uncertainty in the near future. Secondly, we'll talk about diagnostically relevant CMML biology and genetics. We'll also talk about how we prognosticate patients with CMML. And lastly, we'll talk about current and hopefully future therapies for CMML. So as we talked about a little bit yesterday, CMML lies in this group of diseases called overlap syndromes, or MDS/MPNs. And I'll just briefly go over those. They include CMML, which is hallmarked by a peripheral monocytosis, so a monocyte count that's over 1,000. Importantly, that monocyte count should also be 10% of the peripheral differential, because as you can imagine, there may be cases where a white count is, say, 200,000, and certainly we don't want to call something CMML with a monocytosis of, say, 1,500 in that context. So more than 10%, more than 1,000, you have to consider the diagnosis of CMML. It's a disease where cytopenias are common. There's bone marrow dysplasia. That's why it's in this overlap syndrome category. And in general, it's a disease with a dismal overall survival. If you look at all patients with CMML, the median survival is anywhere between 30 and 34 months. About 25% of patients with CMML have splenomegaly, and a large minority, although it's not well represented in the literature, have symptomatology similar to that of MPNs as well, that being spleen-related pain and other disease-related symptoms. JMML, which I've highlighted there, is a pediatric disease we talked a little bit about last night. Atypical CML is what we spent a considerable amount of time yesterday. It's a disease with poor prognosis, hallmarked by neutrophilia that is profoundly dysplastic and can be readily apparent in the peripheral blood. RARST is a provisional category within these overlap syndromes, hallmarked by ring sideroblast associated with SF3B1 mutations, as well as thrombocytosis, which are also associated with mutations in the JAK-STAT pathway, like JAK2 itself or even calreticulin. And lastly, as I said yesterday, my favorite diagnostic classification, which is this MDS, MPN, and classifiable. And what this disease represents is patients who have clear dysplasia and cytopenias, but also have manifestations of myeloproliferation, whether it be leukocytosis or splenomegaly or other. They have both of them, but they don't necessarily fit into any of the WHO boxes. And so there's a fair amount of patients that lie there. CMML luckily has that clear hallmark that you need to have. You have to have the monocytosis. So if you look for it, you should be able to bin it in the right category. This is the other slide that I showed yesterday, but I wanted to emphasize, especially in the context of CMML, which is that MDS, MPNs are not that rare. They're difficult to diagnose, but they're not that rare. And so if you look at the incidence of CMML, for instance, 0.7 per 100,000, even 1 per 100,000 in some series, and you compare that to, for instance, MPNs like myelofibrosis, you find that really it is a rare disorder, but not extraordinarily rare, like I think a general dogma exists. And so I think the one big difference between MPNs, for instance, and overlap syndromes is the prevalence. And that's because, in general, these diseases are much more aggressive. But I also think it means that they're prime targets for novel pharmacologic therapies, because we know what can happen in the experience of CML when you take a relatively rare malignancy and find effective therapy. So these are the WHO criteria for overlap syndromes. We talked about atypical CML yesterday, so we'll focus on CMML today. So CMML, you've got to have the monocytosis, number one. You can't have any of the known fusions like BCR-ABL. Historically, patients that had eosinophilia and CMML had a likelihood of having PDGFR alpha and beta fusions. These patients tend to be sensitive to imatinib. But the latest WHO revision has these neoplasms as their own separate entity. So if you have PDGFR alpha or beta fusions, you're technically not CMML. You should have dysplasia, but one of the hallmarks pathologically of CMML is that the dysplasia is often subtle. And so it's often difficult to say that you have more than 10% dysplasia in one lineage. So what we're often left with is excluding reactive causes or identifying clonality, which we'll talk about in just a minute. So just a review of the hallmarks of CMML. We talked about the monocytosis. Despite being a rare malignancy in the context of other cancers, the genomic spectrum is actually well defined, and that's due to people like Eric Soleri, Torsten Hofferleck, and others. And they've shown that although there's no disease-defining mutation, there appears to be a genetic fingerprint for CMML, which includes mutations in the RAS signaling pathway, epigenetic modifiers, specifically things like TET2, which can occur in up to 50% of cases, and ASXLI, which can occur at similar frequencies. And then more recently, described by Seshi Ogawa, mutations in SRSF2, which can also occur up to 50% in patients with CMML. And so, again, there's no disease-defining mutations, but there's certainly mutations that can help define clonality, and we'll talk about that in just a second. Again, different than MDS, this is a disease where splenomegaly can be present, prominent, and very and be responsible for a great deal of morbidity in CMML patients, akin to that of myelofibrosis. This happens in about a quarter of cases. The median survival is about 32 months. This is derived from an international data set put together from centers across the world that essentially showed about 32 months is the overall survival. And importantly, I think one sort of misnomer that we find is that even though patients with CMML were included in the pivotal AZA-001 trial that showed that 5-azacitidine improves overall survival in high-risk MDS, that cannot be extrapolated to CMML. There were cases here, but it was about 16. They weren't well randomized to each group, and therefore it's difficult to draw conclusions on natural history for 5-azacitidine, and we'll talk a little bit more about that. So how does CMML happen? So this is a grossly inadequate model of CMML leukemogenesis, I think like every model that we try and put in one slide. But what we think happens is that there appears to be a pre-leukemic lesion that occurs at the level of the stem cell. And as fascinating data from Ben Ebert's lab and others have shown, some of these pre-leukemic lesions can occur in patients without any hematologic dyscrasia and persist for quite some time before their development to frank hematologic malignancy. We know in CMML there are a series of mutations that then cause exquisite sensitivity to GM-CSF, and that's from data both in primary samples and in murine models of NRAS-mutated CMML. And ultimately, that hypersensitivity to GM-CSF leads to the characteristic monocytosis that we see in patients. So what about the genomic landscape of CMML? Well, a recent study led by Eric Soleri has performed whole exome sequencing in about 50 CMML patients, and what we find is that there appears to be about 40 recurrently mutated genes in CMML, and that in each patient, if you perform whole exome sequencing, you find about 15 somatic variants per patient. And the mutations that are important are those that have been previously described, the TET2, the ASXL1, and the SRSF2, the so-called big three that can occur in about half of patients with this disease. And then, as I mentioned earlier, mutations in signaling, splicing, and others. When you compare the genetics of CMML to MDS, for example, one thing you find is that it appears that even though the clinical presentation and spectrum of CMML seems to be more heterogeneous compared to MDS, the genetic landscape is more homogeneous. So the number of variants that you see in CMML appears to be less than that of MDS, and this is data abstracted from the Wellcome Trust Group, who published a very large study that included both CMML and MDS. And so how can this genetic data help us in the clinic? I think one clear indication for next generation sequencing in CMML is to sort of validate this portion of the WHO criteria. That is, in those cases, which represent a large fraction of CMML, where the dysplasia in the bone marrow is not overt, and where their cytogenetics are normal, which constitutes about 70% of CMMLs, next generation sequencing can be a crucial test to identify clonality from reactive monocytosis. And so I think this part is very important. I'll talk about a second test that's been recently developed by Eric Soleri's group that can do the same exact thing using flow cytometry. So to sort of validate that concept, one thing that we find is if you sequence only 9 genes, this is data from both Luca Maklavati as well as Torsten Hofferlich, only 9 genes you can identify one somatic variant in CMML in over 97% of cases. And so, again, in my clinic, when I have a patient which is newly diagnosed for CMML, I routinely perform next-generation sequencing, if only to have confidence that what I'm dealing with is actually a clonal malignancy. Another test by flow cytometry that can help do the same thing is one, as I mentioned earlier, described by Eric Soleri. So one thing that they found, and so just a little background, monocytes are actually a composite of 3 subgroups. So there are classical monocytes, which are CD14 positive, CD16 negative, intermediate monocytes, which are CD14 positive, CD16 dim, and non-classical monocytes, which have double positivity. And what Dr. Soleri did is ask the question, what are the monocyte components in CMML? And what he found was actually rather striking. The vast majority of CMML patients have a classical monocytosis, where the intermediate and non-classical monocytes are not present at all. And in fact, using that observation, he was able to derive a cutoff and develop a diagnostic test that has a very high specificity and sensitivity. At the Moffitt Cancer Center, we've actually turned this test into a CLIA-certified assay and have performed it on a wide range of cases, including MDS, CMML, and non-CMML monocytosis, and we tend to find the same thing. We tend to see that in CMML we have a restriction in classical monocytosis, and we find that when they're treated with hypomethylating agents and have a response, the monocytosis is reverted back to a normal pattern. When you look at other variants of monocyte of CMML, like CMML with promonocytosis, you find that it's still restricted to the classical monocyte compartment. But when you look at things like M5 AML, you see that that's not the case. You see that M5 AML has, although an elevation in monocytes, has a normal distribution. And so I think in general, in our clinic, if you combine next-generation sequencing and this monocytosis test, I think the confidence in diagnosis can go way up as compared to morphology alone. So what about prognosis in CMML? We know the median survival is about 32 months, but we also know that this is a very heterogeneous disease. And one thing I think which is a blessing and a curse in CMML is that there's been a lot of work in prognostication of CMML, but that has led to at least 9 different models that can claim to predict prognosis. And that is sort of not something that we should expect people in the clinic to be able to do in a timely manner, is calculate 9 prognostic models and then derive a risk stratification. And so using that international data set, we asked, can we find a best model? Is there a winner out of these? Our goal was not to generate the 10th model. Our goal was to say, is there one of these models that we can vouch for and say, hey, you guys should really use this one? And what we found is that they're actually all valid. They were all well done. They were all done with both internal and external validation sets, so it's not surprising that they're all valid. But unfortunately, all of them perform comparably modest. So when you do statistical tests like the C-index, or others, you find that the area under the curve is modest, anywhere between 0.6 and 0.7, but no real winner, unfortunately. And what I think this tells us is that there may be an asymptote in the predictive power of clinical variables, and that in fact maybe genetic variables in addition to clinical variables could be useful. To that end, there have been the generation of models that use genetics. The most important gene with regards to prognosis in CMML is ASXL1. It has been shown to be independently adversely prognostic in a multitude of studies. And so there are two models that leverage this, the GFM model, which is attractive because it uses, in general, peripheral blood values as well as ASXL1. And there's a Mayo model, which is interesting in that they showed that their clinical model was able to be further refined by the addition of ASXL1. So I think the current models, you can use almost any model that has been generated and claimed to have prognostic significance in CMML, but I think they're all modest, and hopefully in the next 12 months or so we'll have a consensus molecular model that'll help refine the prognosis of CMML. To that end, we found not only ASXL1, but Sybil mutations appear to be prognostic in CMML, and hopefully the combination of data sets from a variety of institutions that have molecular data can help find additional mutations that we can include in these models. So what about therapy in CMML? So the number one, rightly so, the number one question that patients ask is, can this be cured? Are there long, durable remissions with any therapy? And I think there is sufficient retrospective data for allogeneic transplant in CMML to answer that question as yes. It is based on a variety of retrospective studies. It appears that there is a graft versus leukemia effect in CMML, and that there are patients who have long durable remissions with transplant. The open questions remain when to transplant a patient. It is still completely open. In our clinic, we extrapolate data from that in MDS mentioned earlier, whereas patients with high-risk CMML, we send immediately to transplant if they're fit to do so, and those with asymptomatic low risk, we watch. But again, that's complete extrapolation, and the question is wide open. What about cytoreductive agents? So again, clinically, CMML is quite heterogeneous. You can have patients who have splenomegaly, unexplained fever and weight loss, and then another patient with CMML who's got transfusion-dependent thrombocytopenia. And so the biggest take-home point, which we'll talk about in just a second, is that the treatment is symptom-based. But in those that have myeloproliferative symptomatology, cytoreductive agents can be a very appropriate choice. And so there is essentially a grab bag of cytoreductive agents that can include high-intensity therapy like induction chemotherapy, or a variety of more low-intensity therapies like topotecan, Hydrea, oral etoposide, which I tend to use fairly regularly in my clinic because it does have profound cytoreduction in CMML patients, and the insurance companies tend to not have a problem proving that. But things like lenalidomide and melphalan, low-dose erythrocyte, and thioguanine, these have all been tested in small studies and have shown to have cytoreductive capacity. HMA therapy, so although earlier I said there is no data that demonstrates hypomethylating agents to augment the natural history of the disease, there are a lot of phase 2 studies that demonstrate its effect in improving cytopenias. And the response rates that you should expect for hypomethylating agents in CMML are similar to those in myelodysplastic syndrome. That is, about 35 to 40% of patients can have a hematologic improvement as defined by the MDS prognostic or MDS response criteria that we typically use in clinical trials. And so if you have a patient with cytopenias, I think hypomethylating agents are clearly the first-line choice for those patients. Now, just like in MDS, hypomethylating agents have, as I said, a response rate of about 35 to 40%. So are there any assays that can help us predict which patients will have a response to hypomethylating agents in CMML? And I think this is one area where CMML is a little ahead of MDS, thanks to work from Ken Figueroa at Michigan, where she asked a question: if we look at methylation, and not just methylation at promoter regions, but methylation across the genome in patients who have been treated with decitabine, can we predict, based on a signature, who will respond and who will not? And this study was done with decitabine in collaboration with Valerian Santini, and what they found is that there's I believe a 23 gene signature that can be very, very predictive of response to CMML. As a response to decitabine and CMML. And what was fascinating about this signature is that the genes that were located near the the differentially methylated regions are genes associated with and highly expressed in CMML, the CXCL7s and CXCL4, which are genes that are characteristic of inflammatory monocytes. And what they showed in vitro is that these genes are also capable of inducing sensitivity and resistance depending on what you do with those genes in vitro models, suggesting that not only could this be a clinical assay, but could also highlight targetable areas in patients who are hypomethylating agent resistant. The biggest problem with that assay, though, is that it's not clinically available as yet. And so it's promising, but we can't order it in the clinic. To that end, another interesting study recently published was looking at the clonal architecture of patients who respond to CMML, respond to hypomethylating agents in CMML. And one fascinating thing that we found, and this is one of our patients actually, even if you have an incredible response, so this is a patient who had a complete response for 3 years, which is unheard of in CMML with hypomethylating agents, the mutational architecture did not budge. And so this is the patient's whole genome sequencing at baseline, and this is at best response. And you see that the mutations are almost in a diagonal line, and those that are the key drivers, in this case, TET2, EZH2, and SIBL did not change, despite complete resolution of cytopenias. Now, at relapse, they changed dramatically. This patient actually had a loss of chromosome 7 and an expansion of EZH2. So this may suggest that although hypomethylating agents are not cytotoxic, they may improve differentiation in CMML. So how do we measure response? So these typically the responses to CMML have been measured by MDS criteria, which I think have their role certainly, especially in patients who are cytopenic, but don't capture improvements, for instance, in splenomegaly or symptoms. And so a consortium was put together to address this, and new response criteria were generated that do exactly that. For the most part, the cytopenia response criteria are similar to MDS, but what this adds are a symptom component as well as a spleen reduction component. And hopefully these response criteria will begin to be adopted in clinical trials so that we can fully capture the breadth of response in for these agents that we're testing. So how do I treat CMML? So again, the first thing is let's get the diagnosis right. We're in these overlap syndromes that have both MDS and MPN features. And so I think both morphology, the monocyte assay, and NGS for clonality, using all three together, I think you have the best chance of diagnosing CMML patients correctly. Then the most important part, in my opinion, is risk stratification and considering ASXLI containing models. If you have higher risk CMML, again, based solely on extrapolation from MDS, we do send all fit patients for transplant consultation. The next question we ask is, do patients have symptoms? If the answer is no, I think it's reasonable, even in high-risk patients, to observe them. And that's because we know of no drug that alters the natural history of CMML. However, if a clinical trial is available in any context, I think it's quite appropriate to put patients on this, given the poor median survival. If they have symptoms, it depends on the symptoms. So those patients that have rapidly proliferating symptoms, have higher blast counts, perhaps those can even go under induction chemotherapy routes. Those who have cytopenias and more resemble MDS-type symptomatology, hypomethylating agents may be more appropriate. Lastly, I'd like to just take a couple of minutes to talk about GM-CSF signaling as a therapeutic target in CMML. So our lab has demonstrated that GM-CSF hypersensitivity is a feature of CMML and that it can be targetable with JAK2 inhibitors as well as GM-CSF inhibition itself. This was validated in murine models where they knocked out the GM-CSF receptor in an NRAS-mutated CMML model and see improvements in splenomegaly and counts. And so we think that this pathway is a vulnerability for CMML. To that end, we've tested Ruxolitinib, which we heard a lot about in myelofibrosis, just in the last talk by Dr. Mesa. So we asked the question, is Ruxolitinib an effective agent in CMML? And I think the short answer is it may be. This is a swimmer's plot of 20 patients treated in a phase 1 study, and we see that there are patients who have a long duration of response, and the breadth of response is quite broad. There are patients who have improvements in splenomegaly, patients who have improvement in cytopenias, and patients who have improvement in constitutional symptoms. Just like in myelofibrosis, at least early on, we see no changes in mutational architecture. But unlike myelofibrosis, what was interesting is we found no myelosuppression. And so these are spaghetti plots demonstrating either the full change or the absolute value of both platelet and hemoglobin. And in all patients on this study, from 5 milligrams BID to 20 milligrams BID, we saw no patients who had to be taken off study secondary to cytopenias, and in fact saw no measurable cytopenias in any of the patients, suggesting that there may be a different side effect profile in CMML as compared to myelofibrosis. That's all I have for you today. Thank you.